Hello, everybody. Welcome to another episode of HeartBrief. I'm Joel Kahn, medical doctor, triple board certified cardiologist, a preventive practice in Detroit and Florida. So let's go with a couple top articles that have caught my attention in the last week so you can have a bit more of the literature behind you when you see your patients. Let's see if the technology of sharing is going to work. It looks like it will. I had a conversation with a patient today on this topic, which is why I had to search for some literature. Benefits of tadalafil and sildenafil on mortality, cardiovascular disease, and dementia out of University of Texas Galveston. And this American Journal of Medicine article used a giant database, 50 million men in a Trinex X database, more than 40 years old, who they knew had a prescription for either tadalafil or sildenafil, presumably for erectile dysfunction. And they were followed over time. There was a total of actually 509,788 men that were on those drugs for erectile dysfunction, and a little more than a million were on them for lower urinary tract symptoms, probably BPH. And what they found in this study, of course, observational, not randomized, was that if you had a prescription for either tadalafil or sildenafil, the all-cause mortality and follow-up was actually 34% lower than the remaining of the group. And myocardial infarction was 27% lower, quite remarkable. Stroke was 34% lower. And even venous thromboembolism was 21% lower. Maybe most provocative, dementia diagnosis was 32% lower in people on these drugs. It was similar between those that were listed as being on these medications for erectile dysfunction versus those who were on it for lower urinary tract symptoms. So this adds to a growing amount of data in the American Journal of Medicine, volume 138, page 441, that the use of these drugs, which were originally, of course, designed as cardiovascular drugs, switched to sexual support drugs, and are now coming back with the potential, certainly the need to verify, but the potential that these medicines are safe and provide some additional benefits that could be quite profound benefits. So I find that interesting, and it did put this particular patient's mind at ease that he could embark on these medications with not only the expected sexual support benefits, but maybe some additional ones. Maybe is the word. Okay, let's pop over to a second article. Absolutely scary, but important article. And I believe, if I can hone in on it here for a minute, I apologize for the technology that sometimes stymies me, but I believe you are seeing this particular article published in the Journal of Allergy and Clinical Immunology just this week. Implications of a fatal anaphylactic reaction occurring 4 hours after eating beef in a young man with IgE antibodies to something we typically call the alpha-gal syndrome. And this is a case report in New Jersey of a gentleman last year, an airline pilot, who had a burger around perhaps 10 p.m., beefsteak burger, and at 2 a.m. had distress and went to a hospital and actually died. For a while, it was not clear what was the cause of death, but subsequent research has shown it was confirmed that he did not die of coronary artery disease or aneurysm rupture, that he had toxicology consistent with having had an antibody to the Lone Star tick, which has grown from just a small section of the United States on the East Coast to over half of the United States. Some people estimate that perhaps more than 1 million people in the United States now carry an antibody to the Lone Star tick, although there are some additional ticks, including way over on the West Coast, that are causing the same cross-reactivity, and that it causes anaphylaxis. This is the first case report of a well-documented death. There have been many others of anaphylaxis. This has been growing like crazy in the news, particularly around Cape Cod, Massachusetts, where there was a big tick outbreak this summer. So there are blood tests to confirm if you have the antibody to the alpha-gal moiety. And there are people that have to avoid red meat strictly. And the interesting thing is there's also many gelatin capsules and even the concern about a bovine heart valve replacement and other places that cow material is used in human medicine, that people may cross-react and become quite sick. So this is no longer just a small isolated situation in Virginia, as I read about it about 20 years ago. All right, well, we're going to try and see if we can share the last but very important article. Again, one that I find very practical in terms of what I do in my own practice. And I believe, yep, here we go, technology. This was published in Lipids in Health and Disease, switching to rosuvastatin plus ezetimibe in statin-treated stroke patients with an LDL cholesterol over 70 observational study. And this became popular to use a statin plus ezetimibe, formerly known as Zetia, more than 20 years ago. Of course, the Merck pharmaceutical company made them in one drug called Vytorin, but when the drugs went generic, they stopped making the combination, and it's hard to find any combination, so you have to prescribe two medications. And they took more than 1,400 stroke patients at 65 years old. They were on single therapy, a statin. Their mean LDL was 99. And they switched them over to either a combination of 5 milligrams rosuvastatin plus 10 milligrams ezetimibe, 10 milligram plus 10 milligram, or 20 milligram rosuvastatin plus 10 milligram to look at the impact on their lipids. And there is quite an interesting chart here, right here, in fact, that total cholesterols in the upper left was 170. But whether they went on, it looks at 3 and 6 months, any of the combinations of statin plus ezetimibe knocked their total cholesterol down by about 39%. Quite remarkable. I think it's actually 39 milligram per deciliter. I apologize. 22% reduction. If you look over at the right where it says panel B, I think you can see that the baseline LDL was 99, fell to about 62, or about a 37% reduction. And other measures, even the triglycerides fell a bit. Now, in my own clinical experience, where I always prescribe statins with ezetimibe for more than a decade, I also find, interestingly, that lipoprotein A cholesterol, if measured, falls a bit. And if you use statin monotherapy, it tends to rise a bit. So I'm quite excited about that, although I have not put together that data series. And in almost every group they studied, the combination outperformed monotherapy. So that is the three articles I wanted you to know about for HeartBrief this week. I hope they help you in your practice. Consider the alpha-gal syndrome if it's in your area of the United States or the part of the world you live in. Certainly consider the extra sexual supportive aspects of PD-5 inhibitors like tadalafil and sildenafil, and finally, this combination of a low-dose statin plus ezetimibe as a routine measure. The Mayo Clinic proceedings had an article about 3 months ago calling for cardiologists to stop prescribing statin monotherapy and start prescribing dual combination therapy like this paper. I couldn't agree more. Thanks for listening to HeartBrief.